Hello, my name is Amber, and I decided to do my case study on a guy with infective endocarditis. EC is a 32-year-old single male. The patient is currently unemployed but previously served in the Army where he was a flight nurse. The patient smokes at least one pack of cigarettes a day, has a history of alcohol abuse as well as a history of IV drug abuse. Patient reports that he has done meth, cocaine, and heroin for the past 10 to 12 years. The patient also has hepatitis C with a significant viral load of 1.5 million. He has also had dental abscess, which he admits to self-draining frequently, and a cooling of a mycotic cerebral aneurysm earlier in the month. EC presents to UK Healthcare as a transfer via EMS, where he was found with an altered mental status, combative, and attempting to bite people at a local grocery store prior to seizing. En route, the patient received Ativan and Versed and reported to EMS staff that the last time of drug use was yesterday of an unknown substance. On arrival to the emergency department, patient was tachycardic, diaphoretic, and febrile. The mother states that the patient has complained of chest pain, peripheral edema, PND, and orthopnea for the past 4 to 6 months. In the last 24 hours, the patient has also complained of left-sided weakness, headaches, dry eyes, and numbness and tingling. The patient actually told his mother he thought he was having a stroke or a brain tumor. Patient appeared to be somnolent and confused on admission. Auscultation revealed a new murmur, lactic acid was 13, and elevated troponins, and ischemic changes on the EKG. Doctor has new concerns for showered emboli to the coronary arteries. Patient was immediately started on IV vancomycin before taken to CT scan due to the ideation of infective endocarditis, and the patient presented with a fever of 39.3 degrees Celsius. CT scan revealed a right frontal lesion as well as right parietal septic emboli. CT also shows septic emboli showered to the kidneys. Blood cultures later were positive for gram-positive cocci in chains. The echo revealed moderate vegetation of mitral valve and ruptured chordinae, causing flail posterior leaf, severe mitral regurg with flow reversal in the pulmonary veins, and patient was admitted to the hospital and worked up for a valve repair due to positive Duke score. The patient will receive at least 6 weeks of antibiotics, a carotid duplex, full PFTs, as well as a pre-op and post-op TEE. I actually recovered the patient after his valve repair, which later began to leak, so he needed a valve to be placed. After the valve repair, the patient was coming out of the bed before his anesthesia was reversed on maxed out Precedex, as well as a Dilaudid drip, and several fentanyl pushes. Patient was quickly reversed and extubated. The unit stay lasted about 3 days, with the only problem being his pain was unmanageable. The valve replacement course was complicated by increased pain levels to the point that the patient bit through his ET tube and had to be sedated and paralyzed for reintubation, as well as started on levo and epi to sustain blood pressure with all the sedatives. Patient remained PERL at a 3 throughout his stay, except for fresh out of OR, and his pupils were pinpointed at a 1.5. Pulses remained 2/2, lungs clear and diminished, and EMV was a 14 after weaned off sedation and extubated. Patient becomes hypertensive, tachycardic, and diaphoretic with agitation or pain. The plan for the patient included a valve repair, which failed, so he received a new valve. Repeat cultures and change antibiotics until blood cultures are negative and 6 weeks have passed. If cultures test positive for any reason, antibiotics will be continued for longer. Repeat TEE post-op for valve repair. Post-op TE showed mild mitral regurg with preserved LV-RV function and no PFO. Valve would be cultured and gram stained on the original valve. Repeat CTA and MRI in 1 to 2 weeks to monitor brain infarcts, and consult ophthalmology to evaluate ocular involvement. The team also plans to extract 2 teeth and control pain meds with a IV PCA, and once he's out of the ICU, continue with PRNs and scheduled meds. They would also like to consult ID for follow-up during admission as well as outpatient, and consult addiction medicine for counseling as well as continue Suboxone management. On admission, the patient said that he had 16 milligrams per day of Suboxone, as well as monitor renal infarcts. So what is endocarditis? Endocarditis is an infection of the endocardium, which is the inner lining of your heart chambers and valves. Endocarditis usually occurs when the bacteria, fungus, and other germs from another part of your body, such as your mouth, spread through your bloodstream and attach to the damaged areas of your heart. If not treated quickly, endocarditis can damage or destroy your heart valves and lead to life-threatening complications. IV drug users are prone to acquiring needle-borne infections, either from the skin or contaminated injection equipment, drugs, or solvents. Many IV drug abusers are immunocompromised after infected with HIV or, in our patient's case, hepatitis C virus. After researching, the tricuspid valve is infected 50 to 70% of IV drug abuser cases. The mitral and aortic valves are involved in 20-30% of cases. The tricuspid valve may be more susceptible to heroin use, as heroin can cause an increase in pulmonary arterial pressure, creating more turbulence at the tricuspid valve. Substances such as cocaine and methamphetamines, on the other hand, increase systemic afterload, causing increased turbulence at the site of the aortic and mitral valves. Therefore, any shifts in the incidence of right versus left-sided infective endocarditis reflect the availability of certain illicit substances. So how is infective endocarditis diagnosed? It is diagnosed using the Duke criteria. So on the Duke criteria, there is the pathological criteria is positive histology or culture from a pathological material obtained at autopsy or cardiac surgery. Major criteria consist of 2 positive blood cultures with typical organism, persistent bacteremia, positive serology for Coxella, positive echocardiogram for 1 vegetation or abscess or new regurg or dehisce of prosthetic valves. Minor criteria include predisposing heart disease or IV drug abuse, fever greater than 38 degrees Celsius, immunological phenomenon, vascular phenomenon, or microbiological evidence not fitting in the major criteria. Also, classic findings consist of Janeway lesions, ocellular nodes, raw spots, and splinter hemorrhages are rarely seen, appearing in only 5 to 15% of IE patients. Instead, the more common manifestations are complications of advanced stage disease, including septic emboli and organ infarction, which, again, part of our patient's case. When suspecting for IE, a TTE is usually ordered, which detects vegetations and identifies the affected valves. Overall, the sensitivity is 60 to 70%, whereas it can detect tricuspid vegetations with a little higher sensitivity of 80%. However, a TEE has better sensitivity and specificity when compared to a TE. A TEE should be obtained if the TTE is negative. Treatment and antibiotics should be started immediately after blood cultures are obtained. First line of treatment is antibiotics for 4 to 6 weeks. For persistent or invasive infections, refractory heart failure, and prosthetic valves, surgical intervention is indicated. However, the high recurrence rate caused by continuing IV drug use and medical noncompliance inevitably raises the ethical consideration of offering valve surgeries to these patient populations. There has been a continuous debate as to whether it is ethical to withhold valve surgery in an active, noncompliant drug abuser. The first valve surgery is normally offered to those patients who are willing to undergo a drug rehab program and to be compliant with treatment. However, any IV drug abuser who becomes noncompliant, relapses, or acquires a second episode of infective endocarditis generally will not be offered further valve surgeries. So the takeaway from this is most of us in the medical field have dealt with a patient with substance abuse disorder, and sometimes it is very trying. In my experiences, patients have very low threshold for pain and they are often very needy. Oftentimes that patient is also accompanied by a nice mix of family drama, which complicates all other aspects of care. The biggest thing I have taken away from this patient population is they all have a story. I've never talked to a patient who just woke up one day and started using IV drugs. Most of them suffered from uncontrolled pain of some sort, PTSD from war or rape, or a family situation that they wouldn't wish on their worst enemy. As a bedside nurse, I know I am not going to cure an addict, but I know I can make a difference. I can be the face of compassion and sympathy instead of someone who is there to judge them and tell them what a bad person they are. As nurses, we only know what they present with. We don't know what they've been through or how they got there. In the case of EC, his grandmother died a horrific death from cancer, and he knew if he joined the military, he could get an education he needed to be a nurse while also serving his country. After multiple times of being deployed, he returned to the civilian life as an oncology nurse. But civilian life was too much, and the VA was not giving him the care he needed, so he self-medicated with hard drugs to escape from reality. Over the last 10 to 12 years, what he started with wasn't enough, so he added to that in hopes of becoming numb to the world as well as his past. One of the quotes that I try to live by is, "Be kind, for everyone you meet is fighting a battle that you know nothing about."